My name is Dr. Brian Skotko. I'm a medical geneticist from Massachusetts General Hospital and the co-director of the Down syndrome program. And I want to thank you for joining me for a webinar on prenatal diagnoses of Down syndrome. How do we deliver compassionate, sensitive, accurate results in this new age of genetic testing? Here is the accreditation information for this particular webinar. Here are my disclosures for this particular webinar. And I would like to thank the supporters for this program, which are listed here. For this webinar, I would like to discuss and accomplish 3 learning objectives. First, I want to describe the current prenatal testing options available for expectant women today. Before we talk about how we discuss them, how we implement them, I want to make sure we're all on the same page so that we understand what are these new tests, these non-invasive tests, and to have a basic understanding. This is not going to be an exhaustive discussion of the new diagnostic tests, but just enough so that we could all talk about the second learning objective, which is how do we make sure that we're effectively communicating between healthcare professionals and the expectant parents who get this prenatal diagnosis? What are the evidence-based components of that effective communication? And lastly, I want to make sure all of you tuning in today know what resources are available to all of us, the healthcare professionals who want to improve our communication skills so that we deliver these results in the most sensitive and compassionate way. To make sure we're all on the same playing field, I want to make sure we all know there are 3 different genetic flavors of Down syndrome. The most common, trisomy 21, are 3 copies of the 21st chromosome found in all cells in someone with Down syndrome. And about 95% of individuals with Down syndrome have this form of Down syndrome. About 3 to 4% have translocation Down syndrome, meaning that extra copy of that 21st chromosome is attached to one of the other chromosomes. What makes this form of Down syndrome distinctive is that it's this form that can be, although not always, inherited and passed along in families. And then about 1 to 2% of individuals with Down syndrome have mosaic Down syndrome, where some cells, but not all cells, have that extra copy of the 21st chromosome. It's been estimated about 1 baby with Down syndrome will be born for every 830 typical children born, which gives us an estimation of about 250,000 families in the United States and close to 5,000 children with Down syndrome being born each year. When an expectant couple goes to an OBGYN office and they want to say, what are the new tests? What are the tests available for me to see whether or not my fetus might have Down syndrome? There is a whole menu of options. And these menu of options really differ based on where you are in the United States and what is offered at your particular hospital. I like to divide it into the appetizers and the main entrees. So prenatal screens I call the appetizers. Anything in this particular category is going to give you a statistical chance of whether or not your fetus has Down syndrome. The results don't come back saying yes or no. Instead, the results in this category come back in the terms of a chance. You have a 1 in 30, you have a 1 in 4,000, you have a 1 in 227 chance. But it will not come back saying yes or no. If an expectant family wants to know whether or not, yes or no, my fetus has Down syndrome, they have to choose one of the main entrees, or on the right-hand side of your screen, the prenatal diagnostic options. And I want to go through what some of these options are on the prenatal testing menu. There is the triple screen, which is a blood test. Again, this is in the appetizer category, so you're going to get a result that says 1 in something. There is the quadruple screen. There is the first trimester combined screen, which is both blood work and ultrasound findings. An integrative screen, where you get that first trimester combined screen, but then you return in the second trimester for the quadruple screen. And then the sequential screen, where again you get that first trimester combined screen, and based on your results, you decide either with your physician or based on your own understanding if you want to proceed with the quadruple screen for an updated number. But again, any results in this particular category is going to come back in the form of an odds ratio or a chance ratio. If an expectant couple wants to know for sure, they have 2 options under the prenatal diagnostic category. They have chorionic villus sampling, also known as CVS, and that is performed between 10 and 14 weeks of pregnancy. And while the estimates vary, up to about 1 in every 100 will result in a miscarriage. Then there is amniocentesis, which is typically performed after the 15th week of pregnancy, and about 1 in every 400 procedures can result in a spontaneous termination or a miscarriage. Both chorionic villus sampling and amniocentesis involve a needle being inserted into the pregnant abdomen. So the risk of miscarriage comes if that needle is in the wrong place at the wrong time. But as you can see, those miscarriage rates are low, and with increased practice and increased usage from providers, they become even lower. Nothing in medicine is 100%, of course, but you could see that the chances of detecting Down syndrome prenatally is close to 99.9% for individuals getting chorionic villus sampling or amnio. We know from research about 63% of all pregnant women in the United States choose one form of the prenatal screens during their pregnancy, and about 2% choose chorionic villus sampling or amniocentesis. Looking at this, you could see that some women choose none of them. Some women say, well, let me get my odds with the prenatal screen first before I decide whether or not I choose an invasive procedure. And of course, some women can proceed directly to the prenatal diagnostic samples. You see some percentages up there under prenatal screening, 69%, 81%. What do those percentage means? I want to go through them in this table here. In the first column, you see all the fetuses with Down syndrome, and in the second column, you see all the fetuses without Down syndrome. I told you that prenatal screens result in a statistical chance. Let's say that in this particular report, anything less than 1 out of 270 is labeled positive, and anything greater than 1 out of 270 is labeled negative. If you're a fetus with Down syndrome and your results come back, let's say 1 out of 200, that report will have correctly identified you with a, quote, positive result. But if you're a fetus with Down syndrome and your result comes back 1 out of 300, that result will incorrectly label you as negative, because what the results imply is 1 out of every 300 will have Down syndrome. If you go back to these numbers, then we understand what these numbers mean. This means 69% of fetuses with Down syndrome will have a statistical chance less than 1 out of 270 for a triple screen, or 81% of fetuses with Down syndrome will have a statistical chance less than 1 out of 270 for a quadruple screen. But what these statistics do not say is yes or no whether the fetus has Down syndrome. They're based in part on that statistical chance cutoff. But as we're about to get into, women really define those statistical cutoffs differently. The old recommendation was you had to be over that age of 35 before any sort of diagnostic options were offered. But as many of you know, starting in 2007 and 2008, many of the academic societies said all screening and invasive tests, regardless of the woman's age, can and should be offered. But many of you know prenatal testing changed dramatically with the advent of new genetic testing. And this falls into the category of non-invasive, cell-free DNA prenatal screens. And in this part of my talk, I want to bring you up to date on what these new screens are, how they work, and then how we go about incorporating them and describing them. There are 3 basic methodologies that are being used right now in the development or the implementation of these tests. But for this short part of my talk, I'm going to focus on shotgun sequencing and single nucleotide polymorphism, or SNP analysis. How does this work? Well, let's take a dive into a vein of a pregnant woman here. And here you see in this blood system, blood vessel, you have lots of red blood cells, you'll have the white blood cells floating throughout, but you also see itsy bitsy fragments, not full-blown chromosomes, but fragments of DNA from the mother that are not in a cell. I've always found this fascinating, that we have DNA that doesn't need a nucleus, and it is free-flowing in a parent. Research was then done that says, well, do fetuses, and by extension do the placentas, also have this cell-free DNA? And the results from researchers are yes, indeed. The placenta, which is derived from the same embryonic tissue, almost always from the fetus, does have the cell-free DNA. So the way this test works is the fetal DNA goes through the bloodstream in the placenta and starts circulating, as you can see here, represented by these white fragments of DNA. The question then becomes, if you have a fetus with Down syndrome, do you have an overabundance of itsy-bitsy materials from the 21st chromosome, that chromosome which is triplicated? So when we add up mom and we add up fetal chromosomes, itsy bitsy fragments of cell-free DNA together, is there an overabundance? Let's take a look at what the research says together. The research started in 2008 with this seminal paper published, and this is how the data is presented. So they find these itsy bitsy fragments of DNA. They're able to code them and figure out what chromosome they came from because we have decoded the full human genome. And they find a little bit of itsy bitsy fragments and they say, oh, this came from chromosome 4. This came from chromosome 13. This came from chromosome 5. And they put them in there and they're not distinguishing whether or not those fragments are from the mom or from the fetus. But here is bucket 21, chromosome 21, where they throw all itsy bitsy fragments in there. Let's zoom in now to this part of the graph. Again, on the y-axis, we have the amount of material, the itsy bitsy DNA that has been present. Each red dot is a different pregnant woman who has a fetus with trisomy 21. Each blue or black symbol is from a mother who does not have a fetus with trisomy 21. Again, where the dots fall on that y-axis is the amount of maternal plus fetal material from the DNA that's found floating throughout from the 21st chromosome. And you could see in this seminal paper, the hypothesis proved true. There is an overabundance of DNA material when you have a mother who has a child or a fetus with trisomy 21. So they draw a line here and they distinguish the two. But you could see that there's not a lot of dots here. And so what we then started to see in our research literature is really papers starting to get larger with a larger number of participants being recruited. This report of major impact came out in the Gray Journal. And again, let's focus on this graph, which we can now read together. Every dot represents a different pregnant woman. And you could see here, we're measuring the amount of material from the 21st chromosome, mom plus fetus, that is there. And these researchers were able to draw a line here, and anything above, they said, well, it's likely a fetus with trisomy 21. Any below, it's likely a euploid fetus or fetus that does not have trisomy 21. But you could see here by observing, yes, there is one black dot that was above the line that would have incorrectly been labeled as a fetus with trisomy 21. So we're oftentimes asked, what are the accuracies of these particular tests? And of course, in medicine, in clinical implementation, we have 4 different ways of measuring accuracy. Sensitivity means if you are a fetus with Down syndrome, what are the chances this test will pick you up as a positive result? And in this particular sample, it's 100%. Specificity is if you are a fetus that does not have Down syndrome, what are a chance that you're correctly labeled as having a negative result? And that is 99.7, because you see here there was 1 false positive. 2 other ways of measuring accuracy is positive predictive value. This is the reverse. If we give you a positive result, what are the chances that you actually have trisomy 21? In this particular patient sample, in this particular study, came out to 97.5%. Negative predictive value means if we gave you a negative result below the line, what are the chances that it was a typical fetus or a fetus without trisomy 21? And again, for this particular research paper, it's 100%. As many of you know, positive predictive value and negative predictive value really is dependent on the prevalence in a population. So as these tests get enrolled and they're used in other populations, we would expect that these numbers will change. But I'm presenting these numbers here and throughout that are specific to the particular study I'm describing. And in this study and the others, unless I specify otherwise, they're really confined to a patient population that's defined as high-risk expectant mothers. And those are mothers who are either older than the age of 35, have an ultrasound finding that is suggestive of Down syndrome or another aneuploidy, have an immediate family history of someone with Down syndrome or another aneuploidy, or had one of those prenatal screens, those appetizers, that placed them in the high-risk category. So you could see we are studying these accuracy numbers in these research articles based on high-risk women who are more predisposed to having a child with Down syndrome. Here, the N is how many expectant women were studied in this particular study. And for those of you who follow sequencing, I've listed the plex number here, which is how many samples could be run in one lane at one time. So here in one lane, 4 different samples from different women could be run. Next, we start to see that these studies start to get larger in size. So now we have over 1,500 samples. We now know how to read this together, an overabundance of material from the 21st chromosome in fetuses with Down syndrome, not an underabundance if you're typical. A line is drawn here, and you could start to see these accuracy numbers, again, based on this high-risk population. There are samples, however, that are insufficient. They were drawn incorrectly, not placed in the medium that was needed to. By the time they got to the laboratory, they were deemed not able to be used. But then there's also a certain number of samples that meet all sufficiency standards, but fail and are not able to get a result, and so report back no result. Research has started to look, well, what sort of expectant women fall into this category, because we would like to know if we send this result back, what are the chances someone will get a no call? So far in research, it's really dependent on how much itsy-bitsy cell-free DNA is floating in the mother's bloodstream. And are there any variables in which there is a low amount of cell-free DNA? One variable that seems to be statistically true is maternal weight. And here along the x-axis, you have maternal weight, and as a mother has more maternal weight, you could see the fetal fraction decreases, whether you have a fetus with Down syndrome or a typical fetus. Put another way, the more weight an expectant mother has, the more diluted her bloodstream becomes, and therefore the harder it is to detect enough cell-free DNA for the sample to be statistically accurate. Many of you might be wondering, well, this works for trisomy 21. Can't this also work for trisomy 18, trisomy 13, chromosomes X and Y? And certainly the same counting principle does apply. And here are some numbers that came out from the same sort of research and the same style of research. And trisomy 18, you could see the statistical accuracy chances there, and trisomy 13. You might be saying to yourself, well, some of those numbers are not as strong as trisomy 21. And for those of you who are familiar with GC content, those are those DNA subcomponent pieces. If there are a lot of GC content on a chromosome, it makes it more difficult to decode or to read. And on chromosomes 13 and 18, there appear to be more GC content than on trisomy 21, making it more difficult to read. What about women who have twins? Does this testing work for them? There's been one small study done. You could see the N equals 25. Every dark dot here is a woman with a concordant twin, identical twins with Down syndrome. Every open circle is a discordant twin, where one twin has Down syndrome and the other twin does not. All of the other symbols here are twin pregnancies where neither has Down syndrome or trisomy 21. And you can see in the small patient sample, a line again is able to be drawn to differentiate those twins where one or both has Down syndrome and those who do not. What are the companies that are utilizing this technology? Sequenom is one. Their test is called Maternity 21+. Life Codex also has this test available in Germany, Austria, Switzerland, and Liechtenstein, based on the same technology. BGI is yet another, and they have PregnaCare, and this is available in Israel and in China. Building on this technology, there is another company that says, well, why should we have to decode every single chromosome when we're really just interested in a certain number of chromosomes, those of the most common trisomies that make it to birth, on the 13th chromosome, 18th chromosome, 21st X or Y. So rather than spending a lot of energy and potentially time and finances on decoding all the chromosomes, they've designed primers that will go and just anneal or attach to itsy-bitsy fragments that again come from the chromosomes of interest. So let's say this is a itsy-bitsy fragment from chromosome 2 or chromosome 3, which this particular company is not interested in quantifying. And this particular column is an itsy-bitsy fragment from chromosome 21. They will have created a primer, which is a segment of DNA, which will anneal or attach to if it finds its match. Well, this primer doesn't find its match on chromosome 2 or chromosome 3, but it specifically finds a sequence match on chromosome 21. Then using a method called PCR, once a match is made, we're able to over-duplicate or Xerox the number of copies so that when it comes to decoding, we're really enhancing and decoding just those matches from the 13th, 18th, 21st, and X and Y chromosomes. What do these results look like? Well, again, using this technology where we're focused on, the big difference here is rather than being able to just do 4 samples in one lane, you can now do 96 samples in one leg, again, because we're utilizing these primers. And you could see here, based on this small sample of 400, what the accuracy numbers is. Again, I remind you that the positive predictive value and the negative predictive value are specific to this study, but again, those numbers will change based on the prevalence in real-life situation. But there are insufficient samples, again, those that when they arrived at the laboratory weren't up to standards, weren't sufficient, etc. But then those that were up to standards, about 1% failed the test, and there was a no result. This company then had bigger numbers, so we could see in these particular studies we're closing 3,000 expectant women. And again, here's for trisomy 21, here's all those expectant mothers and the amount of cell-free DNA and all the expectant mothers who do not. And you could see how these numbers are starting to change as the sample gets bigger. And the failure of this particular test on this particular study was about 5%. It was this company, however, that did the first result, and as of this webinar, the only result done on the routinely screened first trimester population. So not just women who were in the high-risk category, but women who were routinely screened, including the low risk. This included close to 2,000 women who had a euploid or a typical fetus, and they again counted. And in this particular study, all those with trisomy 21 had a high value, opposed to those who did not. Trisomy 18, high value, and then those who are euploid were low on both the trisomy 21 and the trisomy 18 chart. So again, the statistical chances did seem to pan out in this, again, first study done on the routinely screened in the first trimester. The name of the company really employing this technology is called Ariosa, and their technology is called the Harmony prenatal test. There is another company that says, well, we've been talking about the differential of how these itsy-bitsy fragments stack up. But we've seen that there is this zone right here where there's a little bit of bleeding over, where there's some fetuses with trisomy 21 who have kind of a low total count, and some typical fetuses that have a little bit higher. So it's in this region that I've highlighted in yellow that sometimes you could get the false positives and occasionally some false negatives. So in this particular study, they had this zone which they called the no-call zone for this study. So you got a result either, yes, we think your fetus has it, no, we don't think your fetus has it, or if it fell in this study between 2.5 and 4 standard deviations, they simply made a no-call zone. There was also a no result rate, again, because there was insufficient amount of cell-free DNA to analyze. But I should say that since this company has decided to report its results as either detected, suspected, or not detected. So rather than doing a no call, since it's been implemented, this band or region here is reported as suspected. And the name of the company who is using this technology or this form of informatics is Veronata Health, and their test is called the Verify prenatal test. I would like to review all the shotgun sequencing. Again, this is a simple blood test. Unlike amnio or CVS, there is no risk to the fetus. The sensitivity and specificity specifically for Down syndrome approaches 99%. You saw that those numbers did change a bit with trisomy 13 and 18. It can be performed as early as 10 weeks of gestation, and I reviewed the 3 companies in the United States that have it commercially available as of this webinar. The cost, of course, is going to be dependent in part on whether insurance companies cover that, and increasingly many insurance companies around the country are deciding to cover it. There's about a 10-day turnaround. The advantages is it's just picking up an overabundance of material from the 21st chromosome. So we'll pick up trisomy 21, translocation Down syndrome, and certainly high-level mosaic Down syndrome. Many companies will also report extra genetic material from chromosomes 13, 18, and in some cases X and Y. The disadvantage is it doesn't distinguish between the different forms of Down syndrome. It just tells you there's an overabundance of material from, let's say, chromosome 21, but it wouldn't be able to say whether or not this is translocation Down syndrome or a form of Down syndrome that can be inherited and passed along in families. There was another type of technology called the single nucleotide polymorphism, or SNP technology, and this is just emerging from a fourth company. This really targets, rather than sequencing the whole itsy bitsy fragment of DNA, it's looking at parts of a chromosome, parts of a gene called a SNP. And what a SNP is, a single genetic letter, a single nucleotide that seems to be different from a mother versus a fetus. So in this small SNP, you could see here the mom had a G and C, so did the fetus. Here a mom had a C and G, so did the fetus. Here a mom had an A and a T, so did the fetus. But in this single nucleotide, mom had a T and an A, but the fetus had a C and a G. So that makes there a discrepancy or a difference between the single nucleotide polymorphism. These are naturally occurring. We have lots of single nucleotide polymorphism differences in all of us. But by looking close to over 19,000 SNPs located on chromosome 13, 18, 21, X and Y, this particular company, when sequencing those and through informatics, is able to distinguish when there's a discrepancy between the maternal sequence and the fetal sequence, whether or not the fetus might have one of these aneuploidies. You could see the largest study published using this technology is still small, with an N equals 242. But the company that has made this technology commercially available is called Natera, and their test is called the Panorama test. Now that we understand a bit about how this technology works, I would like to talk about how we implement this and how we communicate this. We do have some guidance, position statements that have come out from the American College of Obstetricians and Gynecologists and the Society for Maternal and Fetal Medicine. The National Society of Genetic Counselors has also produced a position statement. The International Society of Prenatal Diagnosis followed, and then the American College of Medical Genetics and Genomics have also produced some guidelines. Let me share with you what these guidelines say. For all of those guidelines, with the exception of the American College of Medical Genetics and Genomics, which I'll get to in a bit, say these tests have really only been validated in large studies in the high-risk mothers. So they're only recommended for those mothers who meet the high-risk category. And again, those are mothers over the age of 35, those who have an ultrasound finding indicative of one of the aneuploidies, those who have a history of a prior pregnancy, those who have a positive prenatal screen indicative of Down syndrome, or those who already are known to be carriers of those translocations that occur in trisomy 13 or trisomy 21. So again, if they're high risk, going back to our menu, they could start with the non-invasive prenatal screen because they are in that category. However, another way to get into this category is if you're not high risk to begin with, if you're not over 35, if you don't have an ultrasound finding, if you get one of these prenatal screens and it places you in a high risk category, then you're in this high risk category according to many of those academic societies in their position statements. Then if you get NIPS, you're going to have two results. Either it's going to come back negative, at which point the recommendations are an expectant woman can stop there if she chooses. If it comes back positive, or again in that one company, suspected or positive or detected, then the recommendation is to absolutely go on to CVS or amniocentesis in order to confirm that diagnosis, because as we saw through the data, not all positives end up being to a child with Down syndrome. There are some false positives. The American College of Medical Genetics and Genomics, however, have said that all women, regardless of whether in the high-risk category, can and should be offered NIPS. And the basis of this position statement is NIPS still outperforms all the prenatal screens to begin with. And so if we're already suggesting all women of all ages be offered prenatal screening, and knowing that this is at best an advanced screen, this should be offered to all women. Again, if they get a negative, ACMG says they could stop if they like. If they get a positive, then the recommendation from us, from we as healthcare providers, is to offer the CVS or the amniocentesis. But then there's what's happening on the ground. And practically, are women choosing to get NIPS and then saying, I am not going to proceed with any other testing, and then make their own pregnancy decisions based on NIPS alone? And we don't have data yet studying how women respond and how they're utilizing, but certainly this becomes a practical question and how we as healthcare providers guide them through this. I'd mentioned that if women get a negative result on NIPS, all the medical organizations say we can advise them if they want, they could stop there because the negative predictive values for NIPS is so strong. But let's take a look at what the literature says. The literature says approximately 50% of cytogenetic abnormalities picked up by amniocentesis would be missed if women stopped after a negative NIPS that was only looking at chromosomes 13, 18, and 21. When you break it down into these categories, if a woman is less than 35, 75% will go undetected. Again, because when they're younger, they're more likely to have other genetic conditions picked up on amnio than trisomy 13, 18, and 21, which tends to increase as they get older. And when they're in that older category, 43%, however, still will be undetected because of the other things that are picked up on amniocentesis. So this is something certainly to keep in mind and would need to be conveyed to women as they're going through which diagnostic test or screening test is right for them. I want to review some of the other limitations that are part of non-invasive prenatal screening. Unbalanced translocation from untested chromosomes would not be picked up, and again, those, like we just discussed, can be picked up. Sometimes not what we're testing for, but it's picked up anyway on amniocentesis. Microduplications and microdeletions, which are oftentimes being picked up on microarrays, done increasingly so in amniocenteses and CVS, would not be picked up on current NIPS. Again, NIPS is not able to distinguish the form of aneuploidy, can't distinguish between high-level mosaic Down syndrome translocation or trisomy 21. It does not screen for single gene mutations. Uninformative results, that's when we come back saying there's too low of fetal content, where we have no calls, might delay the diagnosis and or eliminate the opportunity to pursue testing if a woman is approaching that legal age where she needs to decide whether or not to terminate the pregnancy or continue. So therefore, the timing of results must be kept in mind. Also, it's not screening for neural tube defects, and therefore serum alpha-fetal protein should still be offered at 15 to 20 weeks of gestation to again screen for those open neural tube defects. Of course, it does not replace the utility of first trimester ultrasound, which we know can pick up the nuchal translucency, but is also helpful in picking up twin pregnancies, multiple order pregnancies, any abnormalities in the placenta, and any other congenital conditions that might exist. We only have limited data on twins and higher order pregnancies, and of course, NIPS has no role in predicting late-term pregnancy complications. You might be wondering, with all of this uptake and the intake of prenatal testing, what is happening to the number of babies being born with Down syndrome as women are making pregnancy decisions based on the new prenatal test? I was asked to take a look at this, and I looked, and people have been counting the number of babies being born with Down syndrome all over the world. But I'd like to focus on here in the United States. And there is one study that was done here, you could see the reference, where the blue line is the number of babies with Down syndrome that could have been born had there been no prenatal testing. And why would that number be going up? Well, as you can see, over time, women have been waiting until they're older to have children. And the older that women are, the increased chances they have of having a child with Down syndrome. So just by the sheer fact of over time, women are waiting until they're older, we could have seen an overabundance in the number of babies being born with Down syndrome. To quantify this, between 1989 and 2006, there could have been a 42% increase. But the red line, based on these researchers' study, is the number of babies with Down syndrome who have actually been born. Now, I must say this is based on birth certificate data, and more accurate studies are forthcoming. But right now, this is the only study right now in the United States that is mapping both. And these researchers point out between 1989 and 2006, there's been an 11% decrease. But more importantly, they point out that the gap between the blue and the red lines are widening as different forms of technology are being introduced. And this was really the portrait, if you will, of expectant women in the United States up until 2006, and it's not including the new technology which we just talked about. Many of you have been asking, well, what do women typically choose when they get that prenatal diagnostic test for Down syndrome? When they get an amnio or CVS and the result comes back positive, what do they typically do? It's important to understand the context of the study. This answer comes from a meta-analysis review, which is only relying on data from 3 states. There's only 3 states who have done population-based studies on this: California, Hawaii, and Maine. And the number to focus on here is this weighted average, which is 74.6%. So in these studies, which are a bit dated in 3 states, about 75% of women who get a positive prenatal diagnosis of Down syndrome through amnio or CVS choose to terminate their pregnancy. For the point of this webinar, I'm not interested in discussing what choices women can or cannot choose. That is a discussion for a different time in a different forum. As a medical geneticist, what I am interested in is, are women, are expectant mothers, able to make informed decisions? And to make an informed decision, they have to have non-directive counseling. They have to have accurate information. The information needs to be up to date, and it also needs to be balanced. So let's take a look at the literature together and see how close we are getting to helping mothers make informed decisions. 81% of medical students say they're not getting any clinical training whatsoever regarding individuals with Down syndrome, and 58% of deans say such training is not a high priority based on all the other demands that need to be crammed into the medical education system. What about the OBGYN fellows in nearly their last year of training? How do they rate their residency? Well, 45% of them on one survey said their training regarding prenatal testing for a fetal aneuploidy was, quote, barely adequate to non-existent, and only 28% of them felt well qualified to talk about general prenatal genetic testing. So certainly what we learn from our trainees and our students is that we're not trained on how to deliver these diagnoses, which can oftentimes be quite complicated and quite sensitive. What about our own personal biases? There was this study that was done that surveyed genetic professionals. These are MD geneticists or master level genetic counselors, or physicians like family practitioners or OBGYNs or maternal fetal medicine physicians who routinely give a prenatal diagnosis of Down syndrome. And on this anonymous survey, these individuals were asked, do you really try to be as unbiased as possible? Do you give the facts and the facts only, in your opinion, so that mothers, expectant mothers, and their partners can make the best decision that's right for them? Or do you purposely overemphasize the negative information so that the natural conclusion is to terminate the pregnancy? Or do you purposely overemphasize the positive information so that the natural conclusion is to continue the pregnancy? Or do you outright say behind closed doors, I think the only thing right for you is to terminate the pregnancy? Or do you outright say the only choice right for you is to continue the pregnancy? Here's how we responded as healthcare professionals. 4% of physicians outright urge parents to continue to term. 10% and 2% overemphasize the positive information. 86 and 63% do try to be as unbiased, non-directive as possible. 13% overemphasize the negative information so that the natural conclusion is to terminate. And 10% outright urge parents to terminate. What I find interesting about this is there are certainly tails on both sides where we in the healthcare professions do say that we're giving directive and not necessarily unbiased information. The genetic counseling community has also been discussing this openly and freely in our journals. In this commentary written in the American Journal of Medical Genetics, Part A, these authors, who are genetic counselors, said, although limited, investigations into the attitudes and practices of genetic counselors suggest they may have a more negative perspective on disabilities than individuals whose lives are directly affected by them. And these attitudes may have an effect on their description of disabling conditions. But then more genetic counselors in the same issue had this correspondence to say, we believe there is significant overlap in the core values espoused by both genetic counselors and the disability communities, and the gap is not nearly as wide as the original authors thought. But in that same journal, this mother who has a child with Down syndrome had the final word, and she said, but over the years, the non-directiveness cherished by genetic counselors seems to have become reason not to share information that might portray people with Down syndrome in something other than a negative light. So the take-home conclusion is, even within the genetic counseling community, there is internal debate on how non-directive their own community can be. What about those women who get the prenatal diagnosis and choose to terminate? How has that experience been for them? Only one study has been done. It's been done in the Netherlands, and you could see that this study was done of women who wanted this pregnancy had it not been for the prenatal diagnosis of Down syndrome. These researchers asked them, why did you terminate? 92% said a child with Down syndrome would never be able to function independently. 90% said the abnormality of Down syndrome is way too severe. 83% said for the child themselves to have Down syndrome is a burden too great. 82% said what's going to happen to this child after I die, my spouse or partner dies. 78% said you can't tell me whether I'm going to have a child with Down syndrome full of lots of medical complications or a superstar with Down syndrome with no medical complications. And it is true, we can't predict, and that uncertainty is too great for 78% of women in this particular study. 73% said the burden for other children might be too great. So these were the motivations, but my colleagues Sue Levine, Rick Goldstein, and I decided to survey families who have a member with Down syndrome across the United States, asking them what is it really like to have a family member with Down syndrome. And you could see we heard back from over 3,000 family members, which included parents, siblings, and for the first time, people with Down syndrome themselves. I'd like to share with you some of these results. In this study that we published on the results from moms and dads, 99% said they do love their son or daughter with Down syndrome. And again, these are all parents who continued their pregnancy or never got a prenatal diagnosis of Down syndrome to begin with. 97% said we're proud of our son or daughter with Down syndrome. 79% said their outlook on life was distinctly more positive because of their son or daughter. However, 5% did feel embarrassed in general still by their son or daughter, and 4% do express some regret by having their son or daughter with Down syndrome. We surveyed brothers and sisters as well, and we said, what is it like to be a sibling? 97% of the younger brothers and sisters, defined between the ages of 9 and 11, said they love their brother or sister with Down syndrome. 94% are proud. 88% said they're better people because of their sibling. 7% said they're embarrassed in general, however, and 4% wish they could trade in their sibling with Down syndrome. You know, as a researcher who worked on this, it's always after the fact you wish you could do another question. And I often wonder in the typical population, how many of us wish we could trade our sibling in for another sibling? And I suspect that it would be higher than 4% here. We asked people with Down syndrome for the first time, what is it like to be you? 99% said they're happy with their lives. 99% said they love their family. They like who they are. They like how they look. They feel they can make friends easily, but 4% did express some general sadness about their life. And again, we are left to compare that to the typical population. Many of you might be asking, well, what are the components of these people with Down syndrome? Are they all the high-functioning families, the high-functioning kids with Down syndrome? To anticipate that, in the parent survey, we asked them to rate the functional skills of their son or daughter with Down syndrome. Can they walk? Can they talk? Can they ride a bike? Can they go on dates? Can they groom themselves? Can they live alone? And the more functional activities they have, we then divide it by age. Since the older you are, the more functional activities we would expect for you to have. We then graphed it, and the gray bars here are the number of respondents. And simply put in the paper, the higher number is the more functional the parent rated their son or daughter with Down syndrome. The lower, the less functional the mother or father later rated their son or daughter with Down syndrome. And this is the number of respondents. We then did a statistical test, and you could see that we had a normal graph, which means we heard back from families who rated their kids as very low functioning, families who rated their kids as, quote, middle functioning, and families who rated their children as, quote, high functioning. And then we said, is there any difference between how the families rate their children and their responses with the parents, with the siblings, and the people with Down syndrome themselves? And on every single statistical test that we did, the answer was no. Put another way, the parents, brothers and sisters, and people with Down syndrome responded the same, regardless of what functional activity they had. This is only a snapshot of these research findings. For more information, I encourage you to check out the original studies. So again, are expectant mothers able to make informed decisions? I would argue that in many places around the country, there is excellent medical care being offered, and they really can make informed decisions. But as a country as a whole, we see that our healthcare professionals saying they're not always trained. Healthcare professionals are sometimes inserting their own personal beliefs. So I think there's still room for improvement as a nation when it comes to all of us helping expectant mothers make informed decisions. So too thought the major medical organizations listed here and two of the national Down syndrome organizations that got together on June 17, 2009 to write this white paper. And in this white paper, they said there are many goals we need to accomplish. but I want to review the three prominent goals. They said together, we need to develop practice guidelines for all of us as healthcare professionals. How should we explain to an expectant mother that her fetus has Down syndrome? What are the best ways to approach this very difficult conversation? 2, how do we all train each other? Because we realize from research that we're not always being trained in our training or in our medical schools. And the information we give to expectant couples. Rather than giving out a pamphlet in Bangor, Maine and another pamphlet in Anchorage, Alaska, can't we all agree that there is consistent gold standard information that can and should be given out? I want to review an update on each of these three, and I'm proud to say that the first moment, the standardized practice guidelines, has now been written. I was privileged to join an incredible team called the Down Syndrome Diagnosis Study Group, which composed of OBGYNs, genetic counselors, maternal fetal medicine doctors, family practitioners, neonatologists, geneticists, a lot of individuals who had expertise in Down syndrome. And we did a review of the literature, and we said, what are the best practices? How do we approach this conversation where we need to tell an expectant couple that their fetus has Down syndrome? I encourage you to check out this research review, but I want to review the top take-home items. Number 1, we've learned from the literature over and over again, the results of prenatal screening, those appetizers we talked about, should clearly be explained as a risk assessment, a chance assessment, and not as a positive or negative result. You might give a result of 1 in 300 to one expectant woman, and she might say, oh, I can rest easy. There's a 99% chance I'm not having a fetus with Down syndrome, and she's very relaxed. You might give that same result, 1 in 300, to another expectant parent, and she's calling you 3 times a day, she's paging you all the time, she is convinced she is that one person. We know we all have different intimacies with numbers, we all have intimacies with odds ratios, and so what expectant mothers have said loud and clear, they want to be given the numbers, the chances only, and they want to interpret for themselves what are positive and negatives. Well, some laboratories actually stamp positive or negative on the report. How do we deal with that? This is the literature that shows us how we're dealing. 9% of us still tell our parents it's positive or negative and nothing more in the United States. 15% of us functionally say normal or abnormal. 23% say low risk or high risk. And only about 35% of us are just giving the numerical risk value. If you are in a place where those results come back and they give you the numerical risk value, and they also stamp positive or negative, the temptation might be, here is this piece of paper, but expectant mothers have said, do not give the piece of paper that says positive or negative. Simply write their number down, because after they get home, after that very cloudy and confusing and emotionally packed conversation, they're going to look down at that paper and they're only going to see positive or negative. And I can't tell you, I see lots of families who have individuals with Down syndrome that see me in the Down syndrome program, and they might say, I don't understand. I had a prenatal test for Down syndrome and it was negative. How do I have a child with Down syndrome? And when I look back through the records, they really only had a prenatal screen, one of the traditional screens, and either they misunderstood or was misexplained, and they really convinced themselves that negative meant negative. The next recommendation is, of course, prior to CVS or amnio, discuss all reasons for a prenatal diagnosis, which is either having the information because a couple wishes to terminate the pregnancy. It is having the information because you want to continue, you want to prepare, you want to get the information ahead of time. Or for some couples, they want to have that information so they can get ready to line up adoption services. There is a National Down Syndrome Adoption Network. This is their webpage. And there is a long number of families in the United States waiting to adopt a child with Down syndrome. So this is a third option that can be offered to families going through prenatal testing if they're interested. The third and the fourth recommendations really go hand in hand. The healthcare professional most knowledgeable about Down syndrome should deliver the news, and likely that's going to be 2 people. And if an in-person visit is not possible, the news should be delivered over the phone or at a prearranged time. Let's be honest, these prenatal tests, we're getting the results back, and rather than calling every single person back and the majority of time saying, okay, you came all the way back, it's negative, okay, they made the appointment in, you don't have slots, why were they there, why did you make them drive in just to get a negative result? We really deliver these results over the phone, and it's those who have positive results, we then invite them in to have a follow-up appointment. So how do we structure these phone calls? Well, what we know doesn't work is some women in the literature have said cold calls definitely don't work. There was a woman who was shopping in the grocery store. She had been shopping there for the past 10 years. She knew that grocery store up and down. The cell phone goes off. She picks up the cell phone. She describes it as her OB, who said, "I wanted you to know as soon as I knew." The test came back positive for Down syndrome. This woman said she couldn't find the exit. She had been shopping there so often, but it was such a startling result. Another mother was teaching, and she's a teacher, and the overhead speaker called her to the principal's office. She picked up the phone. It was the assistant to the medical professional, and the assistant said, "We wanted you to know as soon as possible." The results came back positive for Down syndrome. Cold calls don't work. But what mothers say do work, is they know they're going to have to get this difficult news, is a planned call. So what really works is, okay, Thursday at 3 o'clock, can I give you a call with the results? Oh, that doesn't work for you. Thursday at 4 o'clock, can I give you the results? Okay, that works. So Thursday at 4 o'clock, I am going to call you with the results one way or the other. And if it comes back suggestive or indicative for Down syndrome, I'm going to have one of my colleague experts on Down syndrome join me for that phone call in case you have any questions. So again, that expectant mother could place herself in the setting and in the situation she wants to receive that phone call. On Wednesday at 2 o'clock, she's not worried whether or not she's going to get the phone call. But on Thursday at 4 o'clock, she could decide where she wants to be. Maybe she's at home, maybe her spouse or her partner is picking up on the other line, or maybe they're not. Certainly her mother-in-law is nowhere nearby when that phone call happens, but she can make sure she's in the setting she wants to be. And again, you can make sure that if you're not an expert on all those questions about Down syndrome, you really have a colleague join you for that phone call. Because many of you know who are in this situation, the questions during that first call are not, well, how does this chromosome work? And tell me about the 21st chromosome and talk about translocation. The questions are, what does this mean for my family? What does this mean for my life? What does it mean for my pregnancy? What does it mean for my other children? And oftentimes the best person to answer that question is someone who has seen lots of individuals with Down syndrome. So if you're a member of the OB healthcare professional, you can easily partner with a medical geneticist or someone who runs a Down syndrome clinic or a pediatrician who sees lots of individuals with Down syndrome. So they're on hand if and only if that expectant couple on that phone call has what I call the life questions. What we've also learned is if we don't know, mothers want us to say, great question, but we don't know. There are 3 types of questions that mothers say on that uncompensated phone call you have no time to make. You need to address 3 things. What is Down syndrome? What causes the condition? And we always try to emphasize, whether they ask or not, the fact that they know this is a random occurrence. There was nothing the mother did, nothing the father did that caused Down syndrome. Because mothers oftentimes say they blame themselves for it afterwards. So we want to dispel that. But it's item 6 here. What are the realistic expectations for someone with Down syndrome? So maybe you're able to quote some of the results from the studies that I showed. But more importantly, if there's one variable that really seems to me the most important, it's whether or not we as healthcare professionals offer them a connection with a local parent support group. That is, do we give them a phone number that says, if you really want to know what is it like to raise a child with Down syndrome, here are some other parents who actually have done that, and they could tell you what it's like for their marriage, what it's like for their other children. And if we give that number, it's up to the expectant couple to decide whether or not they make that phone call. They may not never make it. But they have said in their research literature that just by us supplying them with that number, they feel like they were given a lifeline. And whether or not they make it or not, they will rate us more positively from the healthcare community in retrospect. Using non-directive language, of course, there is outdated language. There is the M word that we don't use anymore. It's simply Down syndrome or trisomy 21. We want to make sure that our information, our web pages, are using up-to-date information. We then want to make sure that everyone, when they go to Google afterwards or they go online, that we direct them to appropriate materials. So when we're done with this phone call or the consultations, we say, and would you like me to send you an email with up-to-date materials or bibliography? Again, pointing them in the right direction. And you can find great materials through the National Down Syndrome Associations. Making follow-up appointments, including specialists as needed, especially if there's any cardiac findings that are had. I want to talk about the parent groups. One in particular, there are so many across the United States. Here in Massachusetts, it's called the Parents First Call program. These are trained mothers and fathers who are available 24/7 to talk to new and expectant parents. They can match based on religion, race, or language preference. If you say, I have an expectant parent and she only wants to talk to a Spanish-speaking mother who got a prenatal diagnosis who shares my religion, this group can make that exact match. Some people prefer to talk by phone, some by email, some in person. All the discussions are confidential, and these parents go through training to make sure that they respect that this is a confidential discussion. They share their life experiences, but they don't impress those life experiences on couples who might come from different parts. If you want to find out about a prenatal program near you, you could go to the National Down Syndrome Organization's web pages. The National Society of Genetic Counselors have also published guidelines on how to deliver a prenatal diagnosis and a postnatal diagnosis, and I commend that to you, and it supports all the things that we've just talked about. There's also guidelines on how to deliver the postnatal diagnosis, that surprise diagnosis of Down syndrome from a couple who either didn't get confirmatory testing or chose not to get confirmatory testing, who nonetheless get a surprise diagnosis. For the point of this webinar, we won't be discussing this, but I commend that you look at this particular study, again published by the same Down syndrome diagnosis study group. We just reviewed the standardized practice guidelines. Next was, how do we train healthcare professionals of today and tomorrow? Well, you and I were doing that together right now. Well, what about your trainees? What about your colleagues? There is this interactive tool called Brighter Tomorrows available at this website here, which is funded through federal dollars and then tested in residence in our medical journals, and here are the references here. What this looks like is you go here and you see an actor couple who is coming to their physician wanting a prenatal diagnosis of Down syndrome, and there are start and stop components where you can wrestle with what would you say here. So when the couple starts crying, when you give them the prenatal diagnosis, you could really wrestle with your own emotions. What do I say here now? How do I explain it? What is that conversation? There's also the Prenatally and Postnatally Diagnosed Condition Awareness Act. And this is a federal act that was signed into law by President Bush here. And there's now been state versions of this law implemented in Massachusetts, Missouri, Virginia, and Kentucky. And here is the bill signing that I got to join here in Massachusetts. And this really ensures that we as medical professionals have the information, we have the availability. And once competitive funds are available, if you're interested, you might apply for funds in order to do some in-house training. Well, what are those words you use on the phone with the prenatal couple? What I recommend is when you're making that phone call at that expected time, you say, Mrs. Jones, are you interested? Is this still a good time to have this conversation? And if she is interested in having that conversation, you simply say, the results came back indicative or suggestive for Down syndrome. We don't say, I'm sorry to have to tell you this. Unfortunately, I have difficult news. I'm not sure what to tell you. Because then that's imposing our judgment, our value system on a couple that may not share that value system. Again, we're simply stating what the results are and pausing. Seeing how our patients respond on the phone call and then following up with the resources and the information that they might need. What are the resources? What are the information? Well, here in Massachusetts, based on this law, our Department of Public Health now has a whole website that goes through the resources that are available. But I did tell you that all the major medical groups wanted to make sure there was consistent gold standard information about Down syndrome, and there is finally a material that has been crowned the gold standard information called Understanding a Down Syndrome Diagnosis. And what's most powerful about this small booklet available through that website there is that it was prepared with assistance by all of our major medical organizations and the national Down syndrome organizations. It is not parent propaganda. I can tell you every sentence, every comma, every part of that booklet was reviewed to make sure that it was presenting accurate information, again, in a non-directive way and in a way that was valued and appreciated from expectant parents. The American College of Medical Genetics and Genomics in their policy statement also highlights it is this resource that can and should be given to all couples who get a prenatal diagnosis of Down syndrome. Again, up to them if they choose to read it, but again, our obligation of making sure that we have these materials available. And these materials, this letter case material is also available digitally and for free. We live in a new digital age. And if your expectant couple is into iPad and iPod, you could direct them to this webpage. But I also stress the value of having printed copies of this material in your office space, because there's nothing like having a printed material that when you go home, you could approach when you want, when you're ready. If you have a couple that makes a decision, we are going to continue this pregnancy, and distinctly for that couple, what sort of resources are available for them after they've made that decision? They may have questions like, how do I inform my other family members? What do I put on the birth announcement when my child is born? Do I say Down syndrome? Do I not say Down syndrome? Well, there is a whole website available for them, and in those women, I encourage you to direct them to downsyndromepregnancy.org, where in addition to being able to be connected with other parents, there is a free downloadable booklet that goes through parent to parent all those questions that they might have. And I leave you with this website. If there's one-stop shopping that you need to know, please, when this webinar is over, go to downsyndromediagnosis.org, where you will find all of those resources that, again, are evidence-based, nationally funded, competitively funded, that are available for us as healthcare professionals to, again, make sure that our communication and our outreach with our patients are satisfactory. There are so many people I want to acknowledge and thank. Certainly want to thank Sue Levine and Rick Goldstein, Gil Levine and Heather Riepert, who worked very closely with me on the research that I presented regarding the family attitudes toward people with Down syndrome. That work, my work, and their work was specifically funded by those foundations here, and it wouldn't have been possible without having the assistance of the Down syndrome organizations that helped recruit and disseminate those. Allison Clapp was my librarian, Sion Kim Harris, statistician. The late Alan Crocker was my mentor and friend who guided me on the statistics and how to do that research. And Zoila Martinez translated our surveys into Spanish to make sure we also reached a Spanish-speaking population. So many ways for us to remain in contact. If you have questions, that is my email address. Research is available through my research webpage. I'm happy to be your friend. I do tweet. I have a YouTube channel as well. And if you're interested in our Down syndrome specialty clinic here at Mass General Hospital, that's where it is available. I would like to thank you again for joining me for this webinar, and I hope we still stay in touch. Thank you very much.